residents and other members of staff trickle in, I think we need to start this second half of this lectureship. I want to welcome you once again. This is the 33rd Heavenrich Endowed Lectureship in Pediatrics. And we are glad that we have a very spirited and inspirational speaker who has told us a lot this morning. And you're going to hear more about how to manage pediatric care in a big state and region later on this afternoon. Before we continue, for those who are joining us via Zoom, I also want to welcome you. I'd like to call on one of the Heavenriches to come and say a word or two about the person for whom this lectureship is honored. It will be the grandson of Dr. Robert Heavenrich himself. I won't say much about that. Ben Heavenrich, please say a word or two about your grandson.
Thank you, Dr. Scott. Welcome, everybody. Appreciate it. Welcome to those on Zoom. Thank you so much for being here. Thank you to President Guskowitz for their support. Thank you to Dean Sousa. Thank you to Dr. Scott in English and Dr. Rivara as well for being here. It means a lot. I know to the department, to our family as well. A couple brief things about, my grandfather. I wasn't born in his lifetime. I was born after he passed, which was really unfortunate, but so much of his legacy has been passed on to me. It's very humbling. And when I research him, there's a couple of things that stand out to me, a couple of themes that I find always reoccurring that I think he would want to share if he were here and able to speak in front of this group today. One of those key themes that I always see is, going past the practitioner of pediatrics, right? He was such an advocate for what pediatrics meant as a public health instrument, as a larger piece of society. And so much of what he did, yes, he was known as this really fantastic practitioner, but he was also known as this advocate for public health, this advocate for children, and this advocate for public health and the role that pediatrics played in that world. So I think that's really important. And I think that's a message he would want to pass on and encourage everybody in that field to continue to sort of view it in that paradigm. And then the other two things that sort of stood out to me is when you look at his work and sort of things people say about him as a doctor, there's two words that really strongly tie into the way that he practiced that are very non-medical words. And those words are humor and love. And over again, people mention the manner in which he applied humor and love to the way he cared for his patients and he cared for his work. And that's something I think is sort of a universal message, right? Any of us can take humor and love into the things we do, into the interactions we have with anyone, and you'll see a better outcome as a result of it. So I think if he were here, he'd want something like that said. I appreciate, a few minutes to be in front of you. I'll bring Dr. English up to introduce our lecture.
I want to acknowledge the presence of the Dean's office. We have a Senior Associate Dean for Academic Affairs, Dr. Andrea Wendling. Thank you for coming to represent the college. We do appreciate it. It actually tells us how important this lectureship is to the college. It's my pleasure now to introduce the chair of my department, Dr. Keith English, who is going to introduce the speaker.
Thanks, Jovi, and thanks, Ben. And thanks to the Heavenrich family for sponsoring this important lectureship and to Jovi for leading the committee to organize this for all these years. We appreciate that, Jovi, and we appreciate the support of the Heavenriches. And I'll just say, parenthetically, that we'd all be a lot better off if humor and love were part of the practice of medicine routinely. I think the good news is it is often part of the practice of pediatrics, and it should always be. So, well spoken. So it's a pleasure to again introduce Dr. Fred Rivara as our Heavenrich visiting speaker. As I mentioned this morning, Dr. Rivara has been a pioneer in the field of injury prevention research in pediatrics, established a leading center for the study of injury prevention at Harborview in Seattle, and has really been known nationally and internationally for his pioneering work in this field. He's done as much or more than any other person to make this an important part of pediatric practice and pediatric research. As I mentioned this morning, he's an endowed chair. He has an endowed chair position in pediatrics and is vice chair of the Department of Pediatrics at the University of Washington. He's the editor of JAMA Network Open, and for 17 years was the editor of JAMA Pediatrics. He's won many awards and honors in pediatrics. I mentioned some of this morning. I'll just mention a couple of them now. He's won distinguished awards from the Centers for Disease Control, the American Public Health Association, and the American Academy of Pediatrics. He's won multiple awards at the University of Washington, Distinguished Alumnus of the Public Health Program, and Minority Faculty Mentoring Award, an award given an endowed lectureship in trauma. Nationally and globally, he was elected to the Institute of Medicine almost 20 years ago. It's now called the National Academy of Medicine, a very distinguished academy indeed. And he's won one of the highest awards given in academic pediatrics, which is the Joseph St. Jim Jr. Leadership Award. That's from this Federation of Pediatric Organizations that all work together to promote child health. More recently, and he talked about this report this morning, and I suspect it'll come up over the noon hour as well, he served as a chair of a task force empowered by the National Academies of Science, Engineering, and Medicine to try to determine how to ensure that we have an adequate pediatric access to pediatric specialists for children around the United States in the future. And today at noon, he's going to talk to us about the specific challenge of providing access to care, and for that matter, training people to practice in rural areas. So how do you do that in a big state like Michigan, where many parts of the state are remote enough that it's hard to difficult to get access to a pediatrician, much less to a pediatric specialist? So Fred, tell us how we're going to do this in the future. Thanks for being here.
Thank you. Thanks very much. And again, it's an honor to really be up here giving this Heavenrich lecture. Interesting, Ben, about the idea of humor and love. I, for a while, was something called the George Atkins Professor of Pediatrics. And George Atkins was a practicing pediatrician in Seattle. And his family required me to give an annual lecture. As part of the lecture, I had to speak 3 jokes. It was written into the contract. Well, this morning I spoke with you really about pediatric subspecialty care, and this afternoon we're going to turn our attention more towards pediatric primary care, particularly in rural areas, and how that should affect our training programs, both for medical students and residents. Okay, let's see here. I have no conflicts of interest to disclose. So what are the challenges for pediatric care? As I said earlier today, there's about 72 million children in the United States. And despite all the changes in demographics in the country, that number has not really changed over the last couple of decades. But there's clearly changes in referral patterns for care of children in organizations. I'm sure that even here in this part of Michigan, the referral patterns for kids have changed and probably changed fairly dramatically. This has resulted in big waiting periods for primary and subspecialty care, resulting in long waiting periods. It's not just obviously here, it's not just in Seattle. I was talking to Karen earlier today, and her children need some subspecialty care, and she's got the waits waiting to see a pediatric endocrinologist or a pediatric dermatologist, whatever. We all have those. In Seattle, it's about a 9-month wait to see a developmental pediatrician to rule out autism for your kids. And then, important for the talk today is that access to care varies tremendously with geography. Where you live really determines a lot on how well you're able to access both primary care as well as specialty care. And then this really mixes in with the whole idea of what does our workforce want to do? There's a new generation of workforce that we have. I was talking to Andrea at lunch about it, and clearly it's a new generation of individuals going through medical school, and we have to figure out how do we both meet their needs, but also I think in many ways invite in them the idea of our profession. It's not a job, it's a profession. how do we really instill that into people to realize that they're going to do something very special with their lives? And all of this has created big challenges, and particularly in rural areas. So let's just look at some of the data here. So this is a study that came out a few years ago and looked at 360 different hospital referral regions in the United States. And the bars represent the time for a patient living in a region to be able to find subspecialty care. You can see that for neonatology, you sort of have no problems. Developmental behavioral pediatrics are beginning to see some problems. But look over here at this end, and you can see for rheumatology, you have on the order of 20% of people that live more than 80 miles from being able to see a rheumatologist. And, you know, that begins to be a problem in terms of access to care. And you can see that here, depending on specialty, up to 39 million kids in the United States live more than 80 miles away from a specialist. Here's two examples of, on one, on the left is pediatric rheumatologist, on the right is pediatric hematologist oncologist. You can see the codes here. The white is more than 80 miles. You know, I'll talk in a minute about the WAMI region, which is in this area of the country here. So you can see in much of the WAMI area, they live very far from either a pediatric, very far from a pediatric rheumatologist, a little bit less so for a pediatric hematologist oncologist, but there's still major areas of the country that live very far away. And I guess here in the Upper Peninsula for you, you can see that those people living in the Upper Peninsula, they're all 80 miles away from their rheumatologist or a hematologist oncologist. So there's really issues for people living in rural areas. And, you know, I also work at a burn and trauma center, so always of interest to this. And, you know, what we like to have are people who are seriously injured or burned to get the best kind of care. So the best care is available in the American Burn Association certified pediatric trauma centers. And you can see here that much of this area of the Northwest lives very far, 700 miles from a burn center. Here in Upper Michigan, I guess the Upper Peninsula here, you're not quite as bad, but it looks like you're about 200 miles or so to a pediatric burn center. And then pediatric trauma center. So this was based upon 60-minute access to pediatric trauma center. And in trauma, people talk about the golden hour. It's like we have to get people treated within that first hour of injury to really save their lives and minimize complications. So here you have people that live within 60-minute access to a pediatric trauma center. And you can see the codes down here, level 1 and 2, which is the highest level of pediatric trauma care. But again, you see large portions of the country where kids who are injured in those areas have a long ways to go to take care, to get that kind of definitive care for them. And then here, Alaska, there's none up there. So we, in Seattle at Harborview, get kids flown down all the time from Alaska to get care, whether it be neurosurgery care or burn care. And what's happened over time now, this is a study produced by a few people, Corey McDaniels in Seattle, Jay Berries at Harvard, looking at 2002 compared to 2017. And of kids who live in rural areas, where are they hospitalized? You can see that in 2017, a much larger proportion of those kids are being transferred in major centers. They're not being treated in rural areas. And in terms of metro hospitalizations, again, in 2017, most of those kids are being seen. Over 70% of those kids are being hospitalized in metropolitan areas, not in rural areas. And then in terms of being hospitalized in general hospitals that have less than 1,500 pediatric admissions a year, again, that's gone down. Some of this, as we all know, there's been a closure of critical care hospitals. In smaller community hospitals, there's a closure of both OB units as well as pediatric units. You know, bad enough for pediatrics, but what about OB? A woman have to drive, you know, hundreds of 40, 50 miles to go deliver a baby when they might be in labor. That's a real problem. Up in rural Alaska, for people who live in native villages, they actually fly them into Anchorage and they stay in Anchorage during the last trimester so that they're there available to deliver babies in the hospital. So what's the overall factors that affect this geographic distribution? 90% of kids in the United States live in rural areas. Only 3% of pediatric specialists work in rural areas. And, you know, you can't totally blame that on the specialists. You can't have a neurosurgeon in the middle of Alaska. There's not going to ever be enough business for a neurosurgeon there. There's not enough business for a pediatric cardiologist there. Or subspecialty care has become increasingly sophisticated and dependent upon technologies. We all know that. And it's only the large research centers, children's hospitals, and the large university centers that have the ability to care for those complex children. Higher volume is clearly associated with better outcomes. That's been shown for many years. It's been shown for pediatric, for surgical outcomes, but now increasingly being shown for pediatric outcomes as well. This comes down to where are people trained, and you folks here in Michigan are really doing a terrific job of that. And I'll tell you a little bit what we're doing in the WWAMI region. But 60% of subspecialists who practice in a state where they completed training. So if you complete training in Boston, you know, you're unlikely to be relocating to rural Iowa. And here's across, this is from the AAMC 2 years ago, and across the different subspecialists, the proportion that stayed in the state where they trained. Stayed in the state where they trained. So you can see here, hospital medicine, 79% of those people that stayed in that same state. I guess the low was in cardiology, which is a little surprising, but that's the low at 45% stayed in that state. 55% went elsewhere. But you can see that all the other lines are above 50%. So 50% of the people who trained in that subspecialty in a particular state stayed in that state. There's really a problem in terms of the providing access to care for kids and the maldistribution of care. I mean, you know, Boston has more psychiatrists per square inch, I think, than any other part of the world. And then telehealth, you know, as I mentioned earlier today, it's like we all went from nothing to 60 miles an hour on telehealth during the pandemic. I mean, literally, our hospital, they've been talking about it for a number of years. And within 2 weeks, they had figured out telehealth and got computers set up for it and doctors to do that. And you can see here the change between 2019 and 2021. In primary care, surprisingly, 20% was done by telehealth back in 2019, and 85% of primary care practices in 2021 were using telehealth. So there's been real changes with that, which I think is certainly for the good. And here's a little bit more update. It's gone down somewhat since 2020, but you can still see that here, back here in 2022, on the order of 15% of kids, about 25% of adults had used telehealth during that year. So it's really increasingly being used, increasingly available. And many specialties are really lend themselves well to this. We're talking today, earlier today, about telehealth and neurology for headaches. As long as the kid doesn't have papilledema, you can sort of manage them with telehealth. I did work in concussions. Concussions, you never need to really lay hands on the kid. You can certainly do that remotely. Dermatology, you can do remotely. Certainly, probably the best one is behavioral health services. I mean, giving counseling by telehealth works very effectively and been shown to be as effective as in-person counseling. You know, one of the issues with telehealth is, will states pay for it? And here's a graph from about a year ago of that, which states require their insurers to pay for telehealth and provide telehealth equity. I guess Michigan is not one of those here, but Washington, it certainly is. Any reason that Michigan is not, Keith?
No, I don't. Advocacy.
Pardon?
Advocacy.
Advocacy, something that Dr. Heavenrich was very involved with. Now, where are we training people? And here's a slide, a couple of years old, but it shows where are pediatric residency and fellowship training programs. And you can see here, Idaho, Montana, Wyoming, Alaska. At that time, there were no pediatric training programs located there. In Michigan, you have lots here. You have 6 medical schools, and I don't know whether that's a dot up there or an island. I don't know. Is what?
That's where everybody wants to go.
Everyone wants to go to the Upper Peninsula. So let me talk to you about what's happened out in the Pacific Northwest. So we call it the WWAMI program. Used to be just Washington, Montana, Alaska, Idaho, but then Wyoming joined. And these 4 states make up 25% of the land mass of the United States. 25% of the land mass of the United States. And they're primarily rural areas. You can see that in Alaska, surprisingly, 59% are rural. Anchorage and Fairbanks are the 2 big cities there. But Wyoming, 70% are rural. Montana, 66%. Idaho, 61%. Washington is 17%. That's because of Seattle. If you take out Seattle, it's about 55% rural. Okay. So these are primarily rural populations we're talking about here. They're also frontier counties. So frontier counties are defined as counties that have fewer than 7 people per square mile. And you can see that, I guess that's a Fairbanks up here, but the rest of the Alaska is a frontier county. And then you can see that in the WWAMI region, Idaho, Montana, Wyoming, there are really mostly frontier counties. So delivering care to them is really an interesting problem. How do we go about trying to do that? It looks like Michigan doesn't have any frontier counties. I guess Maine has a few, and then New York has a few.
Yeah.
Oh, you, what? UP, yeah, I'm sorry, there you go, UP is up there, yeah. So just in terms of kind of comparing sort of 2 states, Wyoming is about twice the size of Michigan. Largest city in Wyoming is Cheyenne. It has a population of 63,000. And you can see that Detroit is 10 times as big as Cheyenne. Total Wyoming population is less than 600,000. Michigan, 10 million. So really shows it emphasize the rural nature of some of these states we're dealing with there, though Michigan clearly has a lot of rural areas as well. Then what about the physician workforce in these areas? So, one way to look at this is doctors per 100,000 population. You can see that the US average is 287 physicians per 100,000 population. Washington, Alaska are actually pretty similar to the national average here. Michigan is slightly above the national average. Idaho and Wyoming are substantially below the national average, and Idaho is ranked 50th among the states in terms of the number of physicians per population. So there really is a physician shortage in many of these areas, and that doesn't take into account in this slide the maldistribution within, for example, Wyoming. How many of these live in Cheyenne, versus that live in other parts of the state. So let's talk about this WWAMI model that was developed many years ago. So our medical school is a little bit older than yours. Ours was founded in 1946. And for many years until 2022, it's the only allopathic medical school in 5 states. So Alaska, Wyoming, Montana, Idaho, they still don't have medical schools. There's another medical school that just started 2 years ago at Washington State University, similar to MSU as a land-grant college. But until that, we were the only medical school for those 5 states. And so back in 1971, so a long time ago, they developed this partnership between Washington, Alaska, Montana, and Idaho, and then Wyoming joined it in 1996. And the goal of it was really to provide for citizens in the Northwest, provide them physicians by providing medical education to people that come from those areas. So the way it works is that Wyoming, Alaska, Montana, and Idaho will pay the University of Washington to have a certain number of medical student spots, like 10, 15 spots in a medical school class, to train their students. The students come, and they usually are under some obligation to go back to those states for a while, at least after finishing medical school and residency training. But we're really intent on trying to do that was to really create community-based medical education. We realize we can't just train kids in Seattle. You have to really train people where they come from, where they live. And expand also graduate medical education, not just medical student training as well. And one of the big reasons to do this was to avoid duplication of resources and excess capital costs. I mean, it costs hundreds of $millions to start medical school. It's never cheap, and hundreds of $millions is probably not enough to really get a high quality medical school, and then to attract the faculty to it, as well as just building the buildings. So the idea of these states, I think, was a good idea. Was we don't need to do that. We can just pay University of Washington to train some of our students. So it is a partnership with the University of Washington. It's a sponsoring institution for WME, but we partner with that university. So University of Wyoming, University of Alaska, University of Idaho, Montana State, and then Gonzaga, which is a Jesuit university in Eastern Washington. And it's publicly supported medical education. So it's really funded by the state legislatures in each of those states. And each partner state provides the funding for education in that state. So what about undergraduate medical education? The way it works is that we have an admissions committee based in Seattle, but since 1975, each of the states has its own subcommittees in deciding who to admit to the medical school, to do the interviews of students from those medical schools. Now, the site of basic science education has evolved. Originally, it was the first year at the home university, then second year is in Seattle. And since 2010, that's now been changed to have the first and second years both be done at their home institutions. So people that come from Alaska, they had their first and second years at the University of Alaska. People that come from Montana will have their training at the Montana State University. But from the very beginning, the clinical rotations were completed throughout the 5-state region, including people that were from the state of Washington. They can go to these other states as well. So it's really trying to integrate education as much as possible into these areas where students come from to guarantee that they would go back to those places after they finish training. And here's the pediatric training sites. We were talking earlier to Andrea about family medicine training, and here's our pediatric training sites. I think it's 37% of the third-year clerks in pediatrics do their pediatric training in Seattle. The majority of them do their pediatric training outside of Seattle, in some in other parts of Washington, but you can see they're spread out all over the Pacific Northwest to do their pediatric clerkships. And that's really important in terms of them getting a good feel for what it's like to practice in those areas. And as a result, we have people that go back to the state in which they train. You can see that in the US average as a whole, 39% of students go back to train in this site, go back to practice in this site in which they come from, in which they were residing in when they entered medical school. In Washington is 58%. Wyoming is almost 3/4 of them. Alaska 65%, Montana 58%, Idaho 75%. So this program, in terms of WME, getting the students to really teach from those states, train within this WME system, do residency, as you'll see in a minute, in the WME system, and then go back to those states to practice. It's really been successful. And it's a way of getting those students back in. Andrea, what did you say in terms of how many medical students go back and practice in the state of Michigan? Yeah.
Like 45.
So you're above the national average there. Yeah. So there are two model GME programs within the WME region. One is for the Family Medicine Network, and the other is our pediatric track. And we'll go through those and show you those. So the WME Family Medicine Residency Network was developed 50 years ago. You can see the number of programs here. That's huge. 20 in Western Washington, 7 in Eastern Washington, programs in Idaho, Montana, 1 in Alaska, 2 in Wyoming. Each program admits its own resident class, but they're all affiliated within this Family Medicine Residency Network within the WME region. And then fortunately, 68% of those graduates stay within the WME states. And as we all know, in rural areas, family medicine docs are incredibly important. They are the ones primarily seeing kids. They're the ones seeing them as teenagers. They're the ones taking care of their parents. So being able to have family medicine docs in those areas is really critically important. we love to talk about pediatrics, but family medicine is, I think, really in many ways the backbone of rural healthcare. And here you can see some of the family medicine residency network sites spread out through those programs. And, you know, they're really widely dispersed across the region there. And that's, I think, key to getting people staying in those states after they're trained. And what about pediatric graduate medical education in the Wyoming region? We have the typical categorical residency program. It's majority of we have 45 residents a year now, and most of them are categorical. We require that all second-year pediatric residents spend 2 months in one of the WWAMI sites, whether or not they're going to go into primary care versus specialty care. The sites provide housing. They allow a spouse to be there. They allow kids to be there. They allow pets to be there. Now, Jovi asked, well, can we require that of residents, or will they not come to our program? The residents view this as one of the highlights of their residency training. They love it. And I'll show you in a second slide on that. But you can see we've been doing this for 50 years in Pocatello, 7 years in Billings, and various amount of time over there. So we really have worked that relationship with these organizations for a long period of time. There are clerkship directors in each of these, or residency program directors in each of these sites, but they don't get paid by the University of Washington. We have an overall WWAMI program director, but they're donating their time. But they love having these residents as part of their practices. I mean, we all love being around young people. We all love learning from young people. And so for your practicing doc in a community practice, having some young resident, 25-year-old resident come in there and challenge you in what you're doing, it's terrific. It's really the way we all learn and keep going. And they get fully integrated into the practice in the community. So they take call, they go to the nursery, they go to the inpatient unit at the hospitals, and they work in the clinic. And the clinic is designed to accommodate them so they have their slots. They're not shadowing their primary care doctors there. They have their assigned slots that they see those patients. And we have expectations they'll see a certain number of patients each week in those clinics, and that they take call as well with the practice. So it really is fully integrated into the clinics. They're not treated as medical students. They're treated as part of the practice by the practice docs. So how do you measure the outcomes of this pediatric residency WWAMI training? Satisfaction, recruitment, and where do they work after they finish training? And here's the satisfaction, Jovi. So here you can see different rotations, and the green bar is outstanding. I think that answers your question about whether you can force kids to do this. You don't have to force them to do it. They want to do it because they really enjoy this. They feel like this is the best rotation that they do in their pediatric training. It's been incredibly successful. We've done it now for a long, long time. And people, they know it when they apply to the program. And our residents talk so highly about it that the applicants got excited by it and get the applicants to come in. We have 1,400 people that apply to our residency program for 45 slots. So we get very good resident applicants. And then what happens to them after they graduate from our program? So you can see data for about the last 10 years. You can see that 45% go into fellowships, 19% become hospitalists, and 36% go into primary care. And the hospital medicine is relatively new development. It's relatively new in terms of a separate board of pediatrics. There's a fellowship program, 2-year fellowship program for hospital medicine. You can see we used to have more that went into fellowships. That's dropped down now, and it's really on the order of 45%. But we have 36% of our residents going to primary care. So even though we're at a R1 university, even though we have a big children's hospital that has a big research component, we've got about $120 million a year in research at the children's hospital. Still, primary care is an important choice for a lot of our residents. So you can kind of combine the both. And for many years, the University of Washington was the #1 program in family rate and family medicine, as well as the #1 public university in NIH funding. So the two of them are not incompatible. They are quite possible. And what about this diffusion of trainees from program location to first practice location? Just look at the diagonal here in bold. And you can see across the country here, it's about 50% or so of the trainees end up working in the location where they train. So where they train is really critically important if we are to solve the problem of primary care in various areas. So you are, which are you all? Are you North Central?
Yes.
What? Okay, so you have 51% that stay here. You're losing some to South Central. Some of these are going up to Boston. We're getting 5% out in the Pacific. Few percent leave the country. So it gives you an idea then of how can we work with this problem of trying to get our people who train at a particular spot to stay in that spot to help take care of the physician shortage. This is data from the American Board of Pediatrics that just came out in January, February of this year. So here's where some of our residents who went into these different sites. Here's 4 different sites for their WAMI rotation, their rotation in the second year of pediatric residency. You can see that in Pocatello, Idaho, 5 of the 23 ended up practicing in a WAMI site. Yakima, 5 out of 20. Port Angeles, Washington, which is over the Olympic Peninsula, 6 out of 11. And Bellingham up near the Canadian border, 18 of 31. So again, these people are ending up practicing in more rural areas. They really like the WAMI experience and get exposed to them. And then what about Alaska? Alaska is a special case. And we started a separate residency program there in 2012. It has its own residency match number. But it's run by the University of Washington. And one of the reasons we did it was this map. You can see that this child to population ratio here, the light is less than 30. So I guess here you in Michigan have a ratio of about 30 to 40 kids per pediatricians per kid. In Alaska, it's less than 30. And you can see in these WAMI states, it's really low. So these are the reasons that we tried to develop this Alaska track. So here's Alaska. Yukon is obviously part of Canada here. And here are some of the sites that participated in this program. So Anchorage here, they have a private hospital as well as a Native American medical center there, Native Alaska Medical Center. Fairbanks is where the state capital is. And then they also go to Bethel, Alaska, way out here on the Bering Sea. And you can see then how this is divided up. So they spend about 2/3 of their time in Seattle and 1/3 of their time in Alaska. And it's divided up between Anchorage, Bethel, and Fairbanks. Those are the sites where they are. Bethel is a remote community. You can only get in and out of it by plane or boat during the summertime. And we partnered with the Native American villages up there and Native American communities up there. Talking again to Andrea about the work you're doing up in the UP with the Native American tribe up there. So we divide up the residents into kind of, they either pair with this group on the left or this group on the right, and they go back to that for the 3 years, they go back to the same groups. So the Native Medical Center in Anchorage, and then they go to the Fairbanks Clinic, or they go to the Providence Private Hospital in Anchorage, and they go to Bethel Hospital, Native Hospital in Bethlehem. So they get exposure to both Native healthcare, Native patients, as well as non-Native patients as well, both urban and whatever it means in Alaska, as well as rural in Alaska. And so what's the retention of this? So we just graduated. We have 4 residents a year. We just graduated the last class. So we have 40 people that went through this program so far. 75% of these are working in the WAMI region, and the other 10 are working in rural areas from the other states. So 100% of them are ended up in rural areas. Now, obviously, there's a selection bias who chooses to match this program, but nevertheless, this program didn't screw that up. It didn't end up these people going to practice in Boston or New York City. And only 25%, 10 of these were originally from the WAMI states. Of these, 9 work in the Wyoming State team. So you can see here in the slides, that half of these ended up working in Alaska. So the Alaska program has really been very successful. It's funded by the state of Alaska. Senator McCursky up there has been a big supporter of it. And, you know, they feel, again, that the small amount of money they're investing in this is really reaping dividends for their citizens. Nationally, about 35% of pediatricians specialize, 65% go into primary care. In Alaska, 80% of these are in primary care. So we're really fulfilling that primary care need that we really wanted to do when we developed this track. So in conclusion, there's an unequal distribution of pediatricians in the United States. There's a shortage of primary care pediatricians in rural areas and even in urban areas. The Wyoming approach to decentralized medical education has been successful, and I think really should be looked at as a model for other programs around the country. And with clear goals and stable partnerships and commitment to local capacity building, we can be successful in developing this program. So, thanks very much.
Thank you, sir.
Questions? Comments?
My first, I'm going to ask the first question.
Prerogative here.
I'm convinced more than ever before that the founders of Michigan State University College of Medicine, they were thinking far ahead of everybody else. That's why we started off as a community-based medical school, the only one and the very first one. And it is based on this kind of information that you've just provided. My question to you is this. Do you think every university or every medical school should make a concerted effort to recruit purposefully for community service?
I think that every medical school should be thinking about our vulnerable populations. And how do we provide care to our vulnerable populations, whether they be in rural areas or inner city, urban areas? How do we make sure that those areas are served by that medical school?
Yes.
So whether it's, again, it doesn't have to necessarily be in rural areas. So I don't expect Boston University to provide, pediatricians to Montana. But is Boston University making sure that the kids in inner city Boston are taken care of?
All right, Sean.
Mine's a comment. So I am a graduate of a residency program in Iowa, where we actually had a rotation where I would have a Wyoming-like experience where it was actually, for those of us who watched the show MASH, it was Ottumwa, Iowa, where we ended up being
What's the relationship to MASH there? Is that where it was filmed?
No, Ottumwa was Radar O'Reilly grew up in Ottumwa.
Ah, okay.
They talked about growing up.
All right.
So we did a rotation in Ottumwa, and I did not have to worry about, it was in a hotel, but so I wasn't allowed to take my pets or my spouse, but at the same time, I just knew I could go there and practice medicine. I didn't have to think about where I would go, how I would do that, and I got the experience of being a pediatrician in that setting. So it is it introduces you to a different style of medicine, a different way of thinking that you don't get if you are in a hospital-based experience, and that's why Gail McGinnis probably started way back then. So the comment that I have then is, why don't we do this in Marquette now? And set up something like that in Marquette, right? That'd be a great experience for students to find somebody who would be willing to work with them in a pediatric environment.
So we've been talking to the hospital system in Marquette with the Oakland Lake Superior for them, 7 hours from here, about having some pediatric residents from home boss go to the occasional month there working with our players. We have a clerkship there, right? We have medical students training on our main campus. Francis Starr, the pediatrician there,
We have students there who would be opportunities for other students to go spend some time there. Guess what, Fred? They find the same thing. People come there to do further training. Other people decide this is another place to do it. Maybe we'll practice here. They've never thought about it before.
And I was just suggest, Sean, as you as a pediatric specialist can now appreciate what it's like to be a doc in the rural community.
Absolutely.
And what do you need to tell them when they call you on the phone?
That, now you think about logistics, what is needed, what is necessary around that, and I fall back on that experience. And when you have a family, not having that place where you just go. And I think what the big difference is, I'm so excited about it. You just go there. That's when you just go and you just learn. You take it in.
Let's continue this conversation a little bit. Dr. Wendling, who is actually one of the experts on community-based training, is right here. Maybe she has a word or two to say about what we are discussing right now.
Maybe you should come down so the,
Yes, let them
Zoom
say-
audience
sure.
can hear you.
Yeah,
And we were talking about this at lunch, that we have a really well-defined infrastructure. For medical students.
Just sit with me.
Oh, geez. Do I have to? Thank you. We were talking about this at lunch, that we have a really well-developed infrastructure for medical students across our state. And we have a well-developed structure for family medicine residents throughout the state as well, including Marquette, Alpena, Traverse City, Midland, like throughout the state, basically, but not so much for other residencies. With the MyDocs program recently, which is a state-funded residency program slots that are given to colleges, we've been able to expand that. So we have some additional rural training tracks for family med residencies, and then recently added a 2-year psychiatry residency into Traverse City and into Marquette. They spend 2 years either in Lansing or Grand Rapids and then 2 years there. And so we're working on it. We're moving towards that. We haven't done it with pediatrics yet, although again, we were talking about it at lunch with Keith. But yeah, to think about how to start with those months to be able to build that into our programs, I think is exactly where we need to go.
yes, Steve.
I love this idea, of course, and as you pointed out, we have 3 pediatric residencies with us in family medicine residencies. So I see this as part of the statewide pediatric learning community. Take advantage of the family medicine structure. Do when you're trying to get your family physician and pediatrician. Do a great job taking care of in rural America. And my question for Fred is, how do you connect the talk to the community? Your talk at noon. How are we going to deploy? How are we going to use the expertise of those primary care docs and connect them with pediatric specialists in care of different remote areas? So there's not going to be physical presence of those pediatric specialists.
Well, I think it comes down to a lot of what we talked about this morning in terms of training. So are we really training those primary care pediatricians to take care of the kinds of patients that Dr. Heavenrich did when he was in practice? Or are they kind of taking care of just the well kids or the kids with snotty noses and ear infections? So we really need to be training them to be all around competent pediatricians that can take care of 90+% of the kids that they see come in the door. And then for the other 10%, to use telehealth, teleconsults, and occasionally you'll have to send a kid into the center to be seen. But I think we have to get these primary care pediatricians well-trained out into the community to take care of the vast majority of those kids.
Especially for mental behavior. Especially that.
Well, mental and behavioral health is really obviously a huge need in this country. I would say to you, that's probably one of the areas where telemedicine and telehealth is best suited.
Absolutely.
I know what you feel, Jim,
I
about
agree.
that.
Yes.
It's something that you can do with a patient, and there's good data to show it's actually quite successful.
Yeah. Anybody who is attending via Zoom with questions?
Let's see here. Oh, here we are.
Okay.
Thank you very much.
A medical student at Michigan State was wondering what role medical students can play in order to help resident retention in Michigan.
What role medical students can play? You can stay, right? Stay for residency and then stay for to practice as well. But yeah, but exactly, then you can role model. And what we found in the Upper Peninsula program, actually, we looked at 30 years of outcomes of that program. And when we did that study, we were worried that the workforce retention rate might actually go down over time, that maybe we were saturating the Upper Peninsula with physicians. And what we found for each decade of that program is that we were actually recruiting more UP students into the program, and we were having a higher retention rate. So we had more physicians each decade that that program has been around. And so it just shows the need, but it also shows how you can tie all of this together. And we think that some of that is actually that the alumni of the program then are role models to the kids they're taking care of as they grow up, and they're talking to them about how they can train closer to home and how they can serve the Upper Peninsula. And so we see that play out. So yeah, we can do lots of things with the medical students who want to stay.
Is there an extra funding for your WAMI program?
There's each of the states pays for their own medical students
Okay.
to come to the University of Washington.
All right.
We have one of the largest medical school classes in the country. I think it's 250 per year. Because we have 20 from Montana, 10 from Alaska, 10 from Wyoming.
Right.
So it's a lot of students coming in. In terms of our residency WAMI program, no, it's just really built into the program.
Can I, Dr. Scott, can I ask you to say to the pediatricians in the crowd, just to emphasize the importance of what you said about the general pediatricians providing care in these areas? Will you explain to them what you said about HEMONC and what has changed over time as far?
Well, you see, I was telling them that I was one of the first specialists who was doing a telemedicine clinical work with Marquette years ago, about 35 years ago. And then we developed it further that we now started going there person-to-person encounters. We had a pediatric practice in Marquette at that time that was willing to support those patients when we are not there, just by phone calls. When patients had diagnosis of neoplasms, they sent them to us here. We made the diagnosis, we started treatment, and we sent them back to the community where they came from, where the medications and maintenance treatments are administered locally. Over the years, we've lost all of that capability. All of that capability does not exist anymore. So we can't even send them back there because no one there is willing to take a chance to administer chemotherapy to patients with neoplasms. I don't think, as I was telling them, I think a program that was developed in New Mexico called ECHO, which is extension for community health outcomes, will be very, very good for the rural places where we don't have enough personnel, clinical personnel to deliver care. And, I don't know how we can make that a policy. You guys are the policy makers now. So if we can make that a policy, I don't know if the program director for pediatrics here? All right, okay. Is there a requirement for rural pediatrics as part of our curriculum? No. Okay. So it's an elective. So the resident has to want to do it. All right. Well, we can.
Model.
Yeah, exactly. We can copy the model from Washington, make it a requirement, maybe we'll be able to, I don't know whether the residents will like it, but
They'll be adding them to the combo experience, that's also, the administrative person of the company.
yeah,
Follow them in.
yeah.
So that was what we did.
You
I
read?
guarantee you they'll like it.
They will like it.
They will.
Oh, here they are. The residents are here. Would you like it? Anyway, thank you very much. I want to again acknowledge the presence of the Heavenrich family. Jim, thank you very much for all you've done to support this program and to support the lectureship. I cannot thank you sufficiently for your kindness. My boy here, Ben, I'm not going to say anything bad about you, don't worry. Yes, the next generation is taking it over. Shirley, thank you very much for always being here to support us. And as I said, we're going to continue to reach out to all of the donors for Heavenrich and to tell them how successful this has been over the last 33 years. And I hope we can continue this ad infinitum. Dr. Rivara, thank you so much.